Good afternoon, everybody. Welcome to today's event. I'm Dr. Prateek Thambe, Chairperson for the Amox Endocrinology Committee. Today's program focuses on a very important aspect of mother and child care, and that's postpartum hemorrhage. We have so many women who, even today in the 21st century, are dying because of postpartum hemorrhage, which is a preventable cause of maternal mortality. And that's the focus for today's program, to prevent maternal morbidity and mortality. Before we start the scientific proceedings, as always, I'd like to pay my gratitude to our Amox office bearers. Next slide, please. Dr. Rajendra Singh Pardeshi, our president of Amox. My gratitude to sir for giving us his blessings and support for all the events that we do under his direction and under his presidentship. Next slide, please. My gratitude also to Dr. Sujata Dalvi ma'am. She is the secretary of Amox, also an office bearer of Mumbai Society, the joint associate editor of Jogi. Thank you, ma'am, for your support and blessings for all our academic endeavors. Next slide, please. I'd also like to pay my respects to the ICOG office bearers, Dr. Lakshmi Shikhande, the chairperson of ICOG, and Dr. Ashok Kumar, the secretary of ICOG. Next slide, please. For granting us the ICOG credit points for not only this event, but also all the other events which we have done in this experience series. Thank you so much for your support for all of our academic endeavors here at Amox. Next slide, please. We have two very eminent chairpersons for today's program. The first of these is Dr. Kiran Kurtakoti, sir. Sir is currently the Vice President of Amox. In the past, he has served in several roles, including as the chairperson for the MTP committee, not only for Amox, but also for FOXY. He's also been Joint Secretary of Amox in 2009. He's a managing committee member of the Pune Society since 22 years, ex-vice president of POGS, and has several awards to his credit. Sir was to be a chairperson today for the first talk, but unfortunately is held up in an emergency cesarean section. We expect him to join shortly as soon as he is free. Next slide, please. We are also privileged to welcome today Dr. Bhagyalakshmi Nayak. She is a governing council member of ICOG. When I was chairperson for the FOXY Endocrinology Committee, she was chair for the FOXY Oncology Committee. She is also the vice president of AOG in India, honorary secretary of AGY, and the assistant editor of the Indian Journal of Gynecology. We are really privileged to have such a distinguished chairperson today. Thank you, Bhagyalakshmi ma'am, for joining us today. We have two eminent speakers today, the first of whom is Dr. Leela Vyas, and after her will be Dr. Vidya Thobi. To formally introduce Dr. Leela Vyas, she is a senior consultant at Cocoon Hospital in Jaipur. She has also been professor and unit head, IVF consultant, member of the Research Review Board at the SMS Medical College of Jaipur. I have worked with her when she was vice president of FOXY just a couple of years back, and we have fond memories of traveling together, not only to Jaipur, but also other events where Madam was there during her tenure as the vice president of FOXY. Obviously, she has also served as the president and secretary of the Jaipur OBGYN Society, and she's been awarded the Excellence Award by the Jaipur Medical Association way back in 2009. She's here today to speak to us about a very important advance on preventing PPH in the 21st century. We'll be introducing the next speaker, Dr. Vidya Thobi, after Madam has finished her talk. Thank you, Vidya Madam, for joining us. I know you're not well, but you had committed to joining this program, and it's really hats off to you for taking the time and the effort to ensure that you're here with us to speak later on the surgical management of PPH. So without further ado, I hand over the stage to Dr. Leela Vyas ma'am to enlighten us on how can we prevent PPH in the 21st century. Ganesh, you can stop screen share, please.
Good afternoon, everyone. And at the outset, thank you very much to Amox and especially Dr. Prateek was given this opportunity to talk on such a special topic, which is always important for all the obstetricians. Way back when we were doing post-graduation, and because as a third year, when you are in charge of that labor room, 36 hours, you have to do the duty, and that time, if you or to all your seniors, you were talking about that in this week, what we have to do? In this week, we used to say that this week we should not have any PPH. That was the first most important part in our, that is the mandatory you have to do. That the next task, what we will do? We will save our patients from the eclampsia. We will just save from the status. That was the time when we were having this status eclampticus also. So we always said that these all things were our target, that what we used to do, and PPS was the always mandatory things which we used to do that time. I think somebody has taken. Really, I'm sorry, there is some, I think so many presentations are there. Somebody took.
No worries, ma'am. Take your time. Be comfortable. We will wait for you.
And today we are talking about that PPH in 21st century. I think it's in all centuries, all in when we entered in post-graduation in 83, or whether in 80 entered into the medical college, we used to go into the labor room, and then we see that what we have to do to save our mothers. And whether you are working, because I worked in the government medical college for last around 32, 33 years, and then entered into the private sector. Everywhere the same problem was going on, how to prevent all these PPH. And still we are working as a team member in, is it visible on screen?
No, ma'am, you'll have to share screen. Your screen is not yet shared.
Yes. It's coming on screen, but I think Ganesh, you can share this presentation?
Yes, ma'am, we can share it from our end.
I think so. We have to do this. There is something, because it's so many presentations are coming in between that.
No worries, ma'am. Do you want me to share?
Yeah, you can share.
I can share you the presentation which I have. Will that be okay?
I'll add on now, because I have something I have added, but I'll just speak on that. No problem.
No worries, ma'am. You'll just have to say next. I will share my screen.
That I'll do.
Ganesh, you will have to spotlight madam's video, because the moment I share, my picture will be highlighted. You can go ahead, ma'am.
Yes, this all we were talking about, that prevalence around 38%. I think everyone, no one is, I think any of these obstetrician can't say that I had not faced a critical situation in their career regarding this postpartum hemorrhage. It may be of, we all know the different types of different reasons to have this postpartum hemorrhage. And this postpartum hemorrhage is in India, that is the most common cause for the maternal deaths. That is around the 56% of the maternal deaths because of the postpartum hemorrhage. And really, we are working, all are working. Next slide, please. We are all working hard for this to prevent this disaster to happen in any of the labor room. So I think now the time is that we have so many things in our hands, so many knowledge has been spreaded about to how to prevent this PPH and how to tackle these PPH if it occurs. What is the importance of readiness and all these things? Then one day, I think we will able to write that our hospital is zero, means PPH hospital. Means for the last 1 year, means we have to take a target about that in this month. As I have already explained that during our post-graduation, we used to take that. In this week, we will not have that. So like that, everyone has to take this under their consideration, and to all their staff, their junior doctors, they should be sensitized about that. If single PPH occurs, a single lady dying, your incidences just increases. The hospital gives, yes, we have lost this time 1 patient in whole 1 year. But if you think about the family about that, the family has lost 100% of that lady. So these are the patients, those antenatal patients coming for the during the labor pains, they are not the patients. They are a lady who holds that family. The whole family is around her, and the family has come to get something extra from us, means a new member in their family. And if you are losing anything, or even not the mortality, even a severe morbidity occurs, what the condition of a family, you can feel that. So next, please. So this, if it classify it as primary and secondary, yes, definitely the primary one is very important thing, which we have to take care. And then secondary part, yes, at all because of your quality care. I would like to say that once the Foxy is hard working on this maternity quality care as a Manyata, and in the government sector also, these Rajasthan, we had initially one program, the Dakshta, now the Laksh program, which is going on. All staff members, all the paramedicals are trained to tackle these PPH cases. So if you all know that since beginning, you all are going with the 4 T's, that tone, trauma, tissue, and thrombin. So atonic PPH, which accounts around the 70%. Trauma, yes, definitely, if you are not taking proper care, and sometimes still happens. This traumatic PPH in various hospitals. You start with the beginning, that is the sub-centers where the patient is delivered only by the ANMs, or you are talking about the medical college where the residents in style center system, that first year, second year, third year, the SRs are there, the lecturers are on duty, and the professors are on call. Every time, everyone is facing these traumatic PPH, and sometimes we are getting the reference from the outside. Then retained tissue. Yes, that's why we are going to talk how to prevent this retention of the pleasant tissue inside, and we can prevent this PPH. And especially in these cases, we are having secondary infection. If it occurs, the secondary PPH we are getting. And thrombin, yes, definitely the coagulopathies, which is the one of the thing which sometimes we say it is unavoidable, but no, we have to take care. And early diagnosis, we can prevent our patients to going into the disastrous condition. Next, please. So we all talk about there are various risk factors: prolonged labor, multipara, then precipitated labor, the history of PPH, over-distended uterus, because as per infertility treatment is going on, more and more twin pregnancies we are getting, operative deliveries, the cesarean rate, we all know that sometimes the elective, all the murats and all, when patient is not level, we are taking all these patients. So these are the condition, and another that we were talking about the chorionitis. But still, if you are talking about these risk factors are not there, but the incidence of PPH is again with the normal patients. Next, please. That's why we all always talking about the various guidelines which has been given by all our authorities. And we are talking about that WHO says that active management of the 3rd stage of labor, which is a most important part for the prevention of the postpartum hemorrhage. Because in all, if we are going this, I would like to explain these steps again, because on Sunday, I was conducting one panel in Alvar Society. Still, some of our colleagues, they are not aware of that. How to do aware means they all are aware, but the importance of this doing this AMTSL, how it is important, by their statistics, we can come to know that. And again, we convince them that this is the most important part, that all staff should know these things. Next, please. Next slide. And it is a low cost, means without any money, without investing a single penny, just to invest your, I think your attention. This is all your mindset. you have to do the active management of third stage of labor. Even your staff is trained, definitely you are not losing your patient, because they know sometimes in the grand multivariate, second gravida, third gravida, the sister is taking delivery. She should be aware of that. She should be ready for performing this to giving uterotonics just after the delivery of the baby. So the 4 steps, the 4 components of active management of third stage of labor is, as soon as baby delivers, we have to give uterotonics immediately. As per WHO guidelines, if you are talking, that is the 10 units oxytocin intramuscularly we have to give. Then second, this active management, the second part of that second component is that you have to do the delayed cord clamping. So delayed cord clamping, again, that gives you again a time that placenta automatically gets separated. Third part is, once you are removing the placenta from the uterus, you should have that control cord traction. That again prevents you from not only always say that it is only that the inversion of the uterus, but so many other things, because by that time the placenta gets separated. You can see, you just give a pull, you can, if it is an undiagnosed adherent placenta, you can diagnose that by that time, because it becomes a 3 to 4 minutes when you are taking out this placenta. So then the fourth component is that once you remove the placenta, if uterus is not contracted, then definitely you have to do the massage on that. So this active management of the prophylactic administration uterotonic we have given, and then this reduces the postpartum hemorrhage incidence about 50%. Means you are safe that 50%. And then the second part, next slide, please. Second part, if we are talking about the different components of proper care of this third stage management and proper care of readiness for the PPH, if everything is ready in your labor ward or in your OT, your PPH tray is ready, your instruments are ready, you suspecting whether it is atonic, yes, the different drugs are available. And that is why I'll again quote that Manyata certification is why it is important that every staff is knowing where is your PPH kit. That PPH box or the PPH tray, you call it as a, one is the medical part, and another is your, I think screen has gone or something. And secondly part is that that is the instruments. So readiness, what is so much of importance of that readiness for the drugs means that your staff can bring that this cannula, which type of cannula. It's a wide bore cannula you need. That BT set is there because most of the hospital IV line you put in when the patient comes. But if it requires that you have to collect the sample for the blood grouping cross-matching and the patient is bleeding, then definitely immediately you have these all vials set in position. The different drugs are there. Sometimes your sister is working with you. You have this misoprostol even. So you can put that. By the time she will bring other injections, you can put that misoprostol also, because as you have to work in emergency and you have to prevent that PPH. So the readiness is so important. So in case of normal delivery or in case of cesarean sections, this cesarean section we definitely know slightly higher incidence in cases of as compared to the normal delivery. So there are statistics that they say that approximately 36% of cesarean deliveries are complicated with the PPH. But yes, definitely with their readiness and with your mindset like that, we have to prevent the PPH. Yes, the incidence is decreasing. So this now again we have a new drug which is the carbetocin, which is again recommended for the routine administration immediately after. Means it has been included into your active management of third stage of labor where you are using the uterotonics. So the drug of choice is your, one is the oxytocin, another is your carbetocin, then even the misoprostol in very low resource settings setups. Yes, there is some contraindication regarding the ergometrin. That's why it's the second line of the drug for use, and definitely the carboprost as and when you are required. So these are the various eutotonic drugs which you know that you give. Always you know that oxytocin, this is released from your posterior pituitary, and this is another molecule which we are lucky to have, this carbetocin. Argat, we already talked about the methyl ergometrin.
Coming through.
Yes, now I got. Am I audible?
Yes, ma'am. Now you're audible. Please go ahead.
Yeah. There was something with the net connection. So two drugs which we were talking about that most commonly use oxytocin. This is duration of action. Its half-life is very less. We all know that 4 to 10 minutes, and duration of action is 15 to 20 minutes. And it must be administered as a continuous intravenous infusion to attain the sustained eutotonic activity throughout the surgical procedure and immediate postpartum period. So yes, this drug has these limitations. Now we have another molecule which we all know, which has a longer duration of action and more half-life is there. So this oxytocin is, this is the for safe medication. This Institute for the Safe Medication Practices added IV oxytocin to their list of the high alert medication, meaning minor errors can cause a significant harm to the patient. Yes, that's it. Always this has been taught to all our students that this oxytocin should not be given straightway as an IV bolus injection. It is to be given always in cases with the infusion or the intramuscular. Yes, we all know this oxytocin has been misused, and there is a very interesting story when I did my post-graduation from Udaipur, and that is a completely of a this tribal area situation. We used to get the patients from the tribal area. We saw so many cases of ruptured uterus that time, and if we were asking history, that the traditional birth attendants, those who were working, because I am the era of that time, the training of the traditional birth attendants was going on by the government of India, and these were taught that they should not give this oxytocin intramuscularly when patient is in labor. They used to, so there's a one terminology, because they to the animals, to ask them that you have you used these drugs which you used to give to your cows or buffaloes. तो वहाँ एक शब्द बोलते थे, हिंदी भाषी कोई बैठा है, that कि तुमने डांडो वाला इंजेक्शन तो नहीं लगाया है. And we usually get this history of giving this oxytocin intramuscular to these patients, those who are coming as a ruptured uterus. So, and because of this misuse, this ban, oxytocin ban, we faced that in 2018. And I think that was our tenure for that time. I was vice president, and we talked to the government of India, we talked to the various companies, and this Foxy has worked hard on that. Our president, Dr. Jaideep Malhotra was there, and Dr. Jaideep Malhotra and Dr. Pratima Mittal, they all from the Delhi, because she was from Agra and she was Delhi, and immediately they have given representation from the Foxy side, and this all problem has been solved, and now we are getting the very free of this oxytocin. Yes, now we all are advancing. Everywhere the advancement is going on, because once the patient is coming, previously the patient, they used to come, they never asked us कि हमारी hysterectomy कैसे go, which route you will do. There were only the two routes, that vaginal and abdominal. They never asked for any instrumentation. Now they are asking whether you are going with the endoscopy, you will use the laparoscope, you will do with the robots and all. So the time is changed, so we should change about that. I'm not anti to the this drug oxytocin. This is the one of the most important drug in our profile, and we are very much friendly with this drug, but still when we are getting the more good product in hand, and comparatively you go with that, one is the another thing which we are getting in armamentarium. Definitely we will compare the things. So comparison, it comes automatically, not of because of any other interest. So we need for the longer acting drug, single dose administration, no variation in the doses regime, and devoid of the repeated administration, and ease of the one-time administration, superior efficacy, some temperature control and all. So by that, that's why we are lucky to have another molecule in our armamentarium of this eutotonic drugs. Next slide, please. So this new molecule, carbetocin, I'll not say the carbetocin, I think very frequently used for the last 3 years. It is used very frequently. So this is another synthetic analog of the human oxytocin with some structural modification. Yes, we all know that if chemically the structures have been modified, these modifications while doing these structural, when some carbon atoms or oxygen hydrogen atoms has been placed, and by this structural modification, it increases the half-life, and that's why there will be a prolonged pharmacological effect of that drug. Next slide, please. And oxytocin too, our teachers, we used to teach our students, oxytocin kab kitna, when you have to give. If it is a smaller uterus, you have to give a higher doses of the oxytocin. If it is a bigger uterus, you have to give a lesser doses. We always say that it will act more in low dose in a big uterus, because this we used to teach our students also in MBBS, because that was the time when we were doing post-graduation. All the undergraduates are coming to the labor room and learning all these things. Now the scenario is totally different. So this was the very shortcut we used to say, just to check it, how many units you have put in a case of a 22 weeks pregnancy IUD that you are going to terminate and putting the oxytocin in that. So this acts by acting through the oxytocin receptors and causes the uterus to contract. So this carbetocin have an oxytocic property, it has a eutotonic property, and anti-hemorrhagic property is also, that has been not very proved scientifically. So we all know that carbetocin is a drug which stimulates, which activates your all oxytocin receptors. So it is an agonist for the oxytocin receptors. So half-life, because it's a long acting, so half-life is 40 minutes and is of 10-fold higher than oxytocin, as we have seen that it is 4 minutes. So that's why it's a duration of action is longer. We can give it is IV and IM, and presently we all are using IV, single IV bolus dose, which we are giving a single dose. And again, I would say that as a part of component of the third stage active management of the third stage, we are using this carbetocin and getting good results. So the single, next slide, please. So again, one dose. This initially, definitely, even I can give my experience that initially we were scared of that single dose will work. And our anesthetist, while doing cesarean, our anesthetist used to ask us, Madam, oxytocin dal do, syntocinon dal do drip mein, can I put that? Because afterwards you will ask that, ma'am, sir, you have to put it that. So initially, when we were not have confidence on this drug, we used to put oxytocin into our drip, while this IV line, by 10 units at least you put there. But now with the working experience and using this drug very frequently, now we have come to that a single dose is effective until unless there is some PPS, then we are adding another oxytocin. So WHO has added this into the essential medicines list of eutotonics for the prevention of excessive bleeding after the childbirth. So these are the endorsement which we are getting. And next, please. So this drug carbetocin is recommended by the WHO as an effective eutotonics in 2018 guidelines, and it is a drug if you, this efficacy and safety of the eutotonics, if we are talking, these recommendations given from this WHO, that the use of effective eutotonics for the prevention of PPH during the third stage of labor is recommended for all birth, and to collectively prevent the PPH, the only one of the following eutotonics should be used: oxytocin, the recommendation, and carbetocin, misoprostol, ergometrin, oxytocin, and ergometrin, fixed doses combinations. These can be used. So this is again, once we get recommendations from our authorities, definitely you will be not caught anywhere. If anything happens after giving a single dose, the litigation, the most of the litigations, if you go with the all history, you talk about among your colleagues, they got litigation because of the PPH. There is, next slide, please. And very interesting story, I'll just tell you. Very in recent past, in last month, one of our colleague, she was having a nursing home. The patient had, low risk patient had, after delivery, after 2 hours, she had this PPH, and she tried everything and she saved the patient. She just explained their relatives. She was all normal, but again shifted into the room and she started bleeding, and she again shifted to the labor room and then started all medication, and then patient moved, and she required to give the 2 units of blood to that patients. In the evening, the patient's attendant came and they were saying, "Madam, बहुत अच्छा scene create किया आपने अपना कुछ earn करने के लिए," because our patient is very normal. So this is again on our head. So always go with the guidelines. You all have these guidelines that this can happen. And we can treat our patient. If we are treating our patients, saving our patients, nobody is going to give us a credit, rather than saying that you have done some drama to earn money. So these are the problems with the obstetricians. So always keep your, as we all said that you always keep these charts in your labor room area, and all the patients, attendant are sitting in that you always say that these are the complications, known complications, and we are using the different drugs to save our patients. So I never heard that these types of stories, one day or another day we are getting, and this PPH is the most common cause which force us or pulls us or put into the difficulty with the litigations. So there are various clinical studies are there, that is oxytocin versus the carbetocin in the management of third stage of labor, and also in the prevention of the PPH following the cesarean section. So if we have time, then only we'll go into the detail. Few of the studies I'll just say. In management of third stage, the intravenous carbetocin versus intravenous oxytocin for preventing the atonic. Yes, intravenous oxytocin, that should be in the infusion form, not the bolus. For preventing the atonic postpartum hemorrhage after normal vaginal delivery in the high-risk singleton pregnancy, a triple-blind randomized controlled trials has been done. Next, please. So with this carbetocin 100 microgram, while we give the slow IV over 1 minute or around 1 minute or 1.5 minutes. Sometimes initially we were very slow, we were giving, but the small dose is there. So 1 minute is, if you create that, it's slow, 1 minute game. When no any reaction we have found in our patients, because initially we were also scared of that. This is again a analog of this oxytocin receptor if anything happens, but no, till date, no any complication we have faced. And this 5 minutes of slow IV over 1 minute period oxytocin, we never tried all these oxytocin directly in any of the patient. So I'm not in favor of this giving oxytocin IV bolus dose. We always give in this, or we give the intramuscularly. Yes, we have done a comparatively study for this use of 10 international unit oxytocin versus 100 micrograms of this carbetocin we are giving. So this is always, we tried these things because in initial days, and we found the good results, and not the published, but yes, data we have that these are the good drugs. So next slide, please. So there are these studies have shown that with the carbetocin, we have got the lesser chances of having, means lesser amount of the blood loss was there. Next, please. So intravenous carbetocin is more effective than intravenous oxytocin for the prevention of atonic PPH amongst a singleton pregnancy with at least one risk factor with the of a PPH. Next, yes, in high risk patients and also in the low risk we are using. There are again studies which say the efficacy and safety of carbetocin in comparison to the oxytocin in active management of third stage of labor. And this was again a study which has been done, and we found that it is a there was no significant difference regarding the side effects between the groups. Yes, all these drugs which we say, we are not comparing these oxytocin. Ultimately, with the various studies, we have come out that oxytocin and is yes time tested, which is everyone is using. It's a very good drug. Carbetocin, which is a new molecule, the benefits are there. It is at heat stable eutotonic, which we can use, because sometimes what happens, we are saying yes, we have all process of this transporting this oxytocin from one place to another place with the energy, which just keeps your fridge remaining ongoing while the electricity goes. And this usually happens into the small centers. So I always say that you should not stock much of the oxytocin with you, but at least the ampules. And if once or twice you have faced the problem with your electricity, then definitely you change these oxytocin, bring the another oxytocin, which are properly transported on the this temperature control. And that time, if you have doubt any time, then definitely this carbetocin is the one of the very important drug, because this happened in one of my center where I am going, because they said, the sister directly said, ma'am, kal gadbad hua hai. This fridge was not running. I asked her that all these, because this was only the maternity center, so they were keeping this oxytocin, and very luckily there was the carboprost was not there, only the oxytocin was there, that was in there, another this pharmacy level. So these are the practical points. Sometimes then you think of that, what to be given in these patients if these problems are facing. This is a very practical problem. This is not written in any of the study or anywhere in that. So by these studies, this carbetocin appears to be effective new drug in active management of third stage of labor in vaginal delivery, and carbetocin can be considered as a good alternative to oxytocin in the active management of third stage of labor in the vaginal delivery. Because all these studies are showing that these have the equal results in these. And definitely, I think Foxy has also made these guidelines. It will come forward in any of the TOG, that it is equally good for to prevention of PPH in our high risk or even in the low risk patients. So prevention in the PPH during cesarean, again, these are the study. I think the same studies, the same final results has come. No significant difference regarding the side effects between oxytocin and carbetocin, and side effects are reported highest in the misoprostol. Misoprostol it's a very good drug. I'll not say no, because I have conducted that thesis. Two of my candidates done their thesis on that. Good results. Yes, few side effects are there. Sometimes we have the high temperature or the loose motions, but it's again a one of the drug. But yes, comparatively, if you go with that, oxytocin and carbetocin are very good and comparable drugs for your management of third stage of labor, even in the vaginal or in the cesarean deliveries. Next, please. So all these studies are there. We can go fast with these studies. Next, please. So the studies has been done. Next, please. So single dose of carbetocin appears to be more effective than oxytocin for the several hours in the uterine contraction through the preventing the postpartum hemorrhage in multiple pregnancy. Yes, one thing is definitely we are sure that the single dose is given here. You have to maintain that oxytocin drip in continuation. But majority of the practical thing, I think my chairpersons, they will give their remarks finally that yes, in practically we see still many of the centers after giving this carbetocin, if they feel that this is a high risk, they start that oxytocin, and that finally there is no studies coming whether it is effective or not effective, the time will tell us. So again, this prevention of PPH by this following LSCS, again, the one study has been done. Then finally, shivering and fever were significantly higher with the misoprostol plus oxytocin. Yes, definitely we know. No significant difference regarding the other side effects. So carbetocin is superior, yes, definitely in these side effects, if we are having this. Then again, study with the ergometrin. Ergometrin we are using very safely, and in few cases, yes, one indication which always I tell to my students, yes, ergometrin or the carboprostol is the drug when you are having a bleeding from the lower segment. Sometimes it is all the placenta previa. It's not exactly in definition of the placenta previa, but you find that placenta is attached into the lower part of the uterus. Yes, definitely, because definition wise, you 2 centimeters away from the internal os, it is not the placenta previa, but it is the low-lying placenta. Definitely, you use the ergometrin or the carboprostol, definitely will get a good results. But yes, this comparison with the carbetocin, I'll do in next time. I'll just check that, because it's again one of the risky factor that you compare with ergometrin in the low-lying placenta, and we think of that how the lower segment is contracted with this carbetocin. Next, please. Next, please. Just one. So carbetocin is a preferable drug in the reduction of the postpartum blood loss with the more safety in the side effects of the profile than the methyl ergometrin melphate. Next, please. There is a Cochrane collaboration that the author's conclusion is that for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for the therapeutic uterotonic compared to the oxytocin. Carbetocin is associated with the less blood loss in the prevention of the PPH for the women who have vaginal deliveries and in associated with the significantly fewer adverse effects. Next, please. So again, we can go fast. Yes, a single carbetocin injection is efficacious and safe on the maintenance of the uterine tone and the limitation of the blood losses in peri and post-operative periods. In addition, carbetocin was able to reduce the pain section and during the postpartum disaster. So these are the now, I think, again, there are studies which say, but the final word from my side is that, yes, carbetocin is equally effective as the other uterotonics with that we are using that oxytocin, then it is a very useful drug. Next, please. And again, that different studies are there in the preeclampsia. Yes, definitely there is no contraindication that we cannot give this drug into that as the, yes, definitely the ergometrin which we are avoiding into the eclampsia patients severe in cases of severe anemia. So this has a free use in the different type of our patients where the some of the uterotonics have the contraindications. Next, please. So this is one of the study in which the comparison between the carbetocin and oxytocin for the prevention of the postpartum hemorrhage in the cesarean deliveries for the placenta previa and accreta. They compare to the oxytocin infusion. Carbetocin can reduce the requirement of additional uterotonics or procedures in the cesarean deliveries for the placenta previa measure. Yes, definitely. That's why I'm saying that the study which has come, but if our colleagues are practically used more and more, yes, I'm in accreta. This is again one of the problem with us, whether we to remove or if accidentally removed, how we can say, yes, additional procedures always required with this uterotonic, sometimes the compression sutures and hemostatic sutures which we apply. Next, please. And again, with the severe preeclampsia, is carbetocin more effective than misoprostol in preventing the incidence of atonic postpartum hemorrhage in the patient where we are doing this cesarean section in these delivery. Next, please. So no clinical data reveals no specialized hazard for the humans based on the conventional studies of the safety, pharmacology, repeated dose, toxicology, genotoxicity, and local tolerance. So carcinogenicity studies have not been performed with the carbetocin due to the single dose nature of the indications. I think this time when in cases of this so many drug carcinogenic effect, we have not found in any of the eutotonic in our drugs. So in carbetocin and carboprost comparison, carboprost we always using as a second line agent in PPS. Carbetocin definitely first line we started using. There are some guidelines from the WHO, not recommended by WHO in the management of the PPH. It is recommended this associated with the yes, because vomiting, diarrhea, and other contraindications are there. Yes, with this drug, there are no other any contraindication we have found to use this drug. Next, please. Yes, in the third stage, we all know that this drug has been taken as a management of active management of third stage of in cesarean, also in the in cases of the vaginal delivery. So patient with the elective C-section delivery and patient with the high-risk C-section and patient with the twin pregnancy. This is. So it's a superior over oxytocin and other eutotonics with respect to yes, prevention of PPH, estimated blood loss, need of the additional eutotonic agents, decrease in the hemoglobin levels, need of the blood transfusion, perception of pain, side effect profile. So yes, definitely, but these comparison, not exactly we say the old time-tested drug, yes, we are using, but this drug has given us the so many other advantages over the oxytocin. So in Indian scenario, definitely the heat stable carbetocin is preferred, and it is not final verdict is that carbetocin proved to be non-inferior to the oxytocin with the ease of the single dose administration. Yes, sometimes it is much of the use in our cases. So superiority of the carbetocin over the oxytocin was discussed in AICOG 2019, and this has been proved that again the statement has been given our Foxy, and this again the more and more meetings are going on and more experience from our colleagues we are getting, and definitely we are finding means no any negative point we have got from our colleagues. Yes, but जो कहते हैं ना एक डर होता है to have that, still the other eutotonics has been still till date we are adding, but with getting more and more clinical data, I think everyone get this confidence that single dose carbetocin can be used as a prevention and also in the treatment of the while this prevention of the PPH. So carbetocin is superior over oxytocin with respect to the prevention of PPH, blood loss, additional eutotonics, and deviation to the hemoglobin and all blood transfusion in all cases is superior over the ergotercloid. Yes, that already we have talked. Next, please. So it is one of a good molecule, heat stable, and available in the pre-filled syringe. I think what the highest temperature will be tolerated by this drug. The efficacy, I think in North India, when the temperature is going, because it is now commonly used. Initially, it was not used very commonly, but in last, I think in 22, I have seen that so many of our colleagues saying, no, ma'am, hame ab acha result mil raha hai. So what will be, there should be a one, Pratik, you can do this study that at the highest temperature which can be tolerated by this. Because वो तो सब बाहर ही रखेंगे. So, and this carbetocin produced by this Blazin, they have got patented over this carbetocin, and that's why I think because of that patented and in the favor of, because it's a life-saving drug, I think the company has gone through the all part that availability rates and everything. So this can be reach up to the every means at the grassroots level, because the deliveries which are going on everywhere in the rural area, which they can get. And I think in the some of the government sectors, they are also procuring this carbetocin, and this will be much more in use and can be prevented in the peripheries. So that will be a much good part of this drug. Thank you.
Thank you very much, ma'am, for a wonderful and brilliant presentation. I think you took us through a journey right from the small primary health centers and the interiors of the country, especially Rajasthan, where healthcare may not be available in a tertiary form all throughout. There are many small pockets where cold chain maintenance is an issue. Refrigerator की issue है. People may not have a refrigerator in a primary health center. Storing oxytocin at the right temperature becomes an issue. And especially for these kind of scenarios, I think in India, carbetocin, which is heat stable and available in a pre-filled syringe form, will revolutionize our treatment. I think that last mile delivery or that last mile gap which is there in our healthcare delivery, this particular molecule has a great potential to plug that, especially when you consider the side effect profile and the room temperature stability. Dr. Bhagyalakshmi ma'am, thank you so much for joining us. Dr. Kiran Kuttakoti sir is held up in a cesarean section, unfortunately, and he was unable to make it in time for the first talk. Any idea regarding the utility of carbetocin in your practice, ma'am? I saw that Cuttack and Bhubaneswar, one of the centers for the champion trial actually. So I'm pretty sure you have some very interesting insights to offer on this molecule.
Yeah, I think that's across the road only because I work in a regional cancer center, but indirectly I was also involved a bit in the project because all of our friends were there in that project. So I think it was a very, very appreciated by all the gynecologists who have used this drug. And even in Cuttack, I think in the private setup, most of the people, gynecologists, have switched from oxytocin to carbetocin. So I think that's as you have told, it's really going to revolutionize, and especially in the last months in the villages. I think because oxytocin most of the time, what you have told about the storage and all those things is really a issue. So I think and I think carbetocin has not come into the government supply as of now. As I understand, it's available commercially. So all the practicing gynecologists have changed over to carbetocin, and I think in a very short while from now, I think carbetocin will also come into the government use.
I think that's a very unique and
interesting
interesting
government
insight.
will get information regarding basic policy makers, they get information regarding this, then can be made available, and that becomes these manufacturers, how they are approaching, how they are saying, because still in the sub-centers, there are the issue of this electricity problems there. They are
electricity, cold chain, and even availability of oxytocin at the right temperature at a stockist level sometimes is an issue. What to talk about small primary health centers. Thank you, ma'am. I think we were all enlightened by your talk with your unique insights as an HOD at SMS Medical College, Jaipur. And of course, having traveled widely all over the country, you know that this molecule has great potential. As you rightly pointed out, we need to have more Indian publications. We need to have more data. And one very unique point which you pointed out is that in summers in India, temperatures can go well in excess of 40 degrees. Already in Bombay, it was 40 degrees just 2 or 3 days back. So
we are getting
it was
48,
quite tough.
49. Because of some reasons, they are not mentioning it at 50 degree. Hota hai wo, 50 tak jata hai. But
I think global warming has hit us in a very big way.
Emergency will be there.
Thank you very much, ma'am. I would request Ganesh to please share screen.
Thank you, Lila madam,
so that we can introduce our next. That we can introduce our next speaker, Dr. Vidya Thobi. While Ganesh is sharing screen, I will just mention that she is the president-elect of Kasoga. She is also a governing council member of ICOG. She's been a past chair for the Foxy Food Drug Medical Surgical Equipment Committee. We've done a lot of work together in the past. We've also done a lot of events together in the past. She has, I think, started work on something like a drug directory, which we hope will be published soon. Maybe when she takes over as the president of Kasoga, I would request Dr. Bhagyalakshmi Naik to please formally introduce our speaker.
Yeah. Thank you so much, Dr. Pratik, for giving me this opportunity. I think I learned a lot about carbetocin from Madam's talk. So it's really a pleasure introducing Dr. Vidya. I think she's a very, very close friend of mine in Foxy. And can you share her CV, please? I think formally I have to read out what all is there in that, but as Dr. Pratik has already mentioned that she was the chairperson of Food, Drugs and Medico Surgical Equipment Committee and has done a wonderful work and has got awards for that also. And that this is the Best Committee Foxy Award, Meru Dara Hansotia Award for 2020. She is an ICOG Governing Council member, Foxy Champion Award in 2019. And she is the National Corresponding Editor, Jogi, President, Bijapur OBGYN Society, has been the secretary, Bijapur OBGYN Society, has 2007. She has publications in various books and contribution to many chapters, has been in Foxy Focus and has been speaker at national and international conferences. And I think she's also advisory faculty of boards in Rajiv Gandhi University and is a postgraduate and undergraduate teacher for the last 30 years. So I think she will be the best person because she has worked in so many areas that she'll be the best person to tell us about surgical management. And I think always, as we have heard from Dr. Leela, it's always prevention is better than cure. But sometimes I think carbetocin will really fail you and you will need some kind of surgical intervention. And I think it will be lovely to hear from you, Dr. Vidya.
Thank you very much, Bhagyalakshmi. It is really nice to hear from you always, and always there are so many stalwarts on the dais now to share their experiences, and it is again a pleasure to share my screen as well as share my views on surgical management. And AMOGS, as I tell always, that it is like my Maheri, what I talk in Marathi, that it is always for my pleasure to share my views on this. So hope my screen is visible.
Yes, ma'am, you can go full screen, please.
Yeah. So thank you, AMOGS and AMOGS Endocrinology Committee. And as I always tell that always it is very great to talk on this subject and talk on the dais of AMOGS and the stalwarts. Thank you, Dr. Rajendra Singh Pardesi, Dr. Sujata Dalvi, and ICOJ office bearers, Dr. Lakshmi and Dr. Ashok Kumar. Of course, Kiran is not there, but Kiran is also a very good friend of mine. So thank you, Pratik, to call me on this topic. And I think you will be better person to be expert on this topic because Mumbai, always we say that there are many tertiary cares and many complicated cases you people handle. Of course, in the medical college, we also do, but the amount of the burden we get everywhere is different. This is always.
Ma'am, sorry to interrupt.
Yeah.
Sorry to interrupt. Can you stop screen share and reshare again?
What happened?
Because it's not seen properly. Your slide share is not being seen.
Oh my God. What has happened?
Nothing. You can just stop and reshare. Usually that fixes the issue.
Not tech savvy like you, Pratik, but anyway, I will stop. Is it visible?
Yeah. Can you go full screen now, please? No, it's not working. I think you present it without full screen. That will be better.
Without full screen?
Yeah, without full screen will be better because your screen is not being seen properly.
Now, any problems?
It's okay, ma'am. You can go ahead.
But I'm not able to see it full screen now. Is it visible now, Pratik?
It's visible, but only part of the slide is seen. That is the issue. The full slide is not seen.
Acha. Something is wrong with the.
No worries. You can go ahead and speak.
Yeah.
This is okay. This is okay. This is fine. Don't go full screen. It's fine. Just present.
Yeah. So this is famous what Fortala said about the woman. Women are not dying because of the disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. So the decision making, whenever we talk, where to stop for the medical management and where to start surgical management is very, very difficult and different. Now also it is not seen.
We can see a slide which says action plan for management of PPH. I think that's your 9th slide.
Dr. Vidya, are you sharing again? You're muted. Yeah, I think now you can make it full screen.
Is it okay?
Yes, ma'am. That's fine. Please go ahead.
Perfectly okay, Dr. Vidya.
Oh, thank you very much. Okay, so we talked all about incidents and everything, and just I was talking about the decision making. So most important decision is when to reinforce the medical management with surgical management to save the life of the mother. So when to stop or when to additionally work on surgical management is very difficult decision, but it is very important decision for the saving of the life of the mother. Because if you don't take proper decision at a proper time, the lethal quad of PPH ensues, that is acidosis, electrolyte abnormalities, coagulopathy, and hypothermia. We always talk of bundle approach, and this bundle approach is very important, which we always I don't know what has happened. It is not moving. My slides are not moving now.
No, your slides are not moving. They are not on full screen also. You can
Madam,
stop
what you
sharing
can
and share
do,
again.
What you can do is you can email me the presentation. I will share again, just like
That
for
is
Dr.
the right
Leela.
thing. Yeah. But you told me that you
Unless you
I
have
made
videos
it
which
the
cannot be
30.
emailed.
Otherwise, no, your screen is minimal. Yeah, you can.
I have now I can talk like this. Okay.
Yes, this is
But you
fine.
can see that.
This is fine, man. Please go ahead.
थोड़ा-सा
Yes.
वाढवा, slightly.
नाही मी ते
You just enlarge a bit.
You can
Slides, you
enlarge a
just
bit.
have to
also.
enlarge them a bit and it will be fine. Yeah, I think this should be okay. No, this is
Hmm.
more. Yes, this is perfect.
this is center.
Perfect. Go ahead.
Okay, this is so I was talking about the bundle approach in PPH. That is a comprehensive approach for the management of PPH, which always considers all the areas from the root to roof and all aspects which may lead to PPH unless taken care. So it includes what we talked of prevention and curative aspects. So here you can see the surgery referral comes at the last end. But you have to always think of these things, like is a leadership, data monitoring, quality improvement, respectful maternity care. But the PPH emergency response rotates on all this bundle approach. Now we talk of action plan of management of PPH, that is hemostasis, and I would like to talk from this stasis, that is a specific surgical management of PPH. So that's what we focus on, that is shift, then think of tissue, trauma and tamponade first, then compression, systemic devascularization and interventional radiology, and lastly, but most important, is a hysterectomy. So this approach covers all the surgical management of PPH. But I'm not going to talk of tamponade, tissue, and little bit of trauma I have included in some of my slides. So what about the newer development in the therapeutic options? The type of surgical intervention depends on several factors, and most important, we always talk of experience of the surgeon. If surgeon is not experienced of any of these procedures, better to shift to tertiary care center. The other factors, of course, for whenever we take the decision is about the parity, desire of future children, the extent of hemorrhage, general condition, of course, and the place of confinement. So if the facilities of blood transfusion or any ICU, HDU is not available, then we have to bring down our whatever the management options are available, like periphery. Then stitch in time saves 9, and traumatic PPH always the bleeders have to be stopped. But what about atonic PPH? When the medical management fails, then we think of these surgical interventions like compression sutures, stepwise devascularization, and hysterectomy. So first, always we talk of compression sutures, and we know the great person, that is B. Lynch. Now, this B. Lynch, which was performed and described by Christopher B. Lynch, and I had an occasion to meet him once or twice, and he demonstrated various modification also and his own technique. So long back in 1989, he developed this when the patient refused a consent for emergency hysterectomy. So consent part is also important whenever we do any surgical interventions. Now, these are the compression sutures which are applied over the atonic uterus in various patterns, upper segment, lower segment, both, and it acts as a brace to facilitate uterine contractions and retractions, similar to effect produced by manual compression of the uterus. So it always stops the bleeding from the plasma side because it opposes the anterior and posterior uterine walls together. So patient positioning is very, very important. Never take the position on the left side. Why the right side, that is Lloyd Davis position? Because we have to see that this compression sutures which we are putting, it is effective, because we have to see any bleeding through vagina or any other exposure. Any traumatic is also there in lower part. So the positioning is very important. And always there is 10 principles we should remember, that is Lloyd-Davis position. You have to exteriorize the uterus. Basic surgical competence is required for putting these sutures. So we have to find out various skill drills. Perform bimanual compression first and take a transverse lower segment incision in the standard Billin suture. Uterine cavity should be checked, explored and evacuated. Sometimes we find some adherent placenta or additional placental lobes, and also you have to always check the uterine cavity. You should explore it and evacuate it. And what are the advantages? Compression technique, it allows the free drainage of blood and always checks the bleeding control and control any vaginally, including any you have to swab and find out any things inside. The suture material which is used should be strong, absorbable, like Vicryl number 1, monocryl, or chromic catgut even number 2. The needle length should be proper, that is at least 70 to 80 millimeters, curved needle, and 8 to 10 centimeters for straight needle. So straight needles are also available nowadays. This is a standard procedure we all know here. I don't know whether my pointer is seen, but we know we have to enter 70 millimeters round body hand needle should be taken. You should enter 3 centimeter here. You can see here 3 centimeter from below the low segment, enter inside, come out the 4 centimeter from the incision, and then go round, come posteriorly, enter the posterior segment, then come out 4 centimeter, go round, and then tie, and then you have to suture the low segment completely. Now here, the properly you should compress the uterus anterior posterior and see that it works. Otherwise, just putting the sutures loosely won't help. So somebody has to compress the uterus from both the sides and tighten it. So it is very useful. So many studies are available on B-Lynch, and the tension should be even. So if you put the proper tension, there is no ischemia and no necrosis. Some people are worried that with the B-Lynch there will be necrosis, but I have put so many, I have not found a case, but there are some of the case reports which are available in the literature. Now, some people, they feel that after some days, these sutures, they will fall down, and sometimes entanglements of intestine or something may happen. So some people are fond of taking the additional bites at the fundus, but I think that is not required as such, because as the sutures, as the involution takes place, the sutures also may become loose, I agree, but I have not found any adhesions or anything of these B-Lynch sutures. Now, this is one of the pictures of B-Lynch. What I could not incorporate the videos. I had told Pratik actually I would send those, but I could not do those. So this is one of the case where the B-Lynch suture is placed. Now, what are the modifications? These are the modified B-Lynch procedure, because they never wanted in normal deliveries. If you want, if the PPH is there, if you want to put B-Lynch, again, you have to open the low segment. So they modified this by Dr. Heyman and of course, our Professor Arul Kumaran. There is no lower uterine segment incision here. Additionally, you can put 2 cervicoischemic sutures also. So cavity is not opened. The uterine cavity is not explored, of course, if anything is there, because it is not, even though it is under direct vision, we are not opening it. Quicker to apply and no feedback data for to slippage of the sutures. I was talking of, that is the shouldering with the venous obstruction. That is 1 or 2 cases are reported with this. Now, this is a cervicoischemic sutures. If there is a bleeding in the low segment, which can be arrested by applying this ischemic cervical opposition sutures, which occludes the placental blood vessels by the apposition of anterior and the posterior wall. So this is how the cervicoischemic sutures are taken. These are again different sutures, like we know these TOG sutures. The straight needle is passed through the bleeding sites to compress the endometrial cavity. Firstly, passed through the anterior to posterior walls, 2 to 3 centimeters laterally. The needle is passed back to the posterior, then anterior wall, and it is moved 2 to 3 centimeters upwards. And the same procedure is repeated in the opposite direction. So knot is tied as tightly as possible, and there is a square suture which is completed. So multiple squared suture, TOG suture can be used for the uterine atony. So this is how it is taken, from posterior to anterior, then come posterior. So it looks like a square. So 4 square sutures can be put, but it requires big needles, and maybe the straight needles would be useful. I have not put any time the TOG sutures. I am happy with the Beeline sutures. So here what happens is the uterine cavity drainage, there is a restriction. So there is always a risk of pyometra, and there is again no feedback data on fertility outcomes. Morbidity feedback or data is also limited. So rhythmic contractions, when it happens, it is not facilitated, and so subinvolution. So involution is impeded, of course, and there is a subinvolution. So these are various compression sutures. I must mention Dr. Gunachila. She had done this circular sutures, compression sutures. But there are 2 to 3 reports with this Gunachila stitch, circular stitch of the necrosis. So these are the few things. And there are other sutures also, which because of paucity of time, I have not mentioned, but I have added in my presentation. Lastly, I can show them. Combined applications like uterine sandwich techniques also have been tried. So Beeline suture can be useful in this way because the use of balloon tamponade, it decreases further bleeding. There is a compression inside. Then you apply for the compression suture and you put a balloon inside. The Beeline technique is the only uterine compression suture which does not occlude the uterine cavity. So it can be used in combination with the intrauterine balloon. So there are various reports in the literature that the success rate of these compression sutures, which is around 92%, they are effective method for the treatment of PPH. So they avoid hysterectomy and they do preserve the potential fertility. One more report, they have done prophylactic compression sutures in cases of over-distended uterus, like delivery of the twins, and they have found that the success rate is 98.6. So if you suspect that these patients are going for atonic PPH, so they have put Beeline sutures in such patients. This one can be even this twins, then over distension in polyhydramnios. Also, they have done. I have seen some of the studies where they found that in all over distended uterus, by any means, they have tried this compression sutures. So overall literature, if you see the overall literature, the hemostatic sutures in arresting PPH and preventing hysterectomy is around 75 to 90%. So they must be used within 1 hour of the delivery, and the chances of success rate are around 85%. So apart from effective, these sutures are very simple. They preserve the menstrual function and fertility. Why they fail sometimes? So one is wrong technique, delayed application, and no intraoperative testism. Means once atonic PPH, you have to compress and see that whether this compression helps. And sometimes additional factors like DIC. In these patients, there is a failure. What about the complications? There are no large published data, but small observational studies and case reports, they show these complications. The short-term complications, they are either cut through, then hematometra, pyometra, or partial and complete uterine wall necrosis due to ischemia, and long-term consequences, as I was talking of bowel herniation, intestinal obstruction, and some of the few cases of Asherman syndrome. Now, the third one is we talk of systematic pelvic devascularization. So this is always a rescue surgery, and ligation of uterine artery and ovarian artery comes the first. The sequencing is unilateral uterine artery ligation, then comes bilateral uterine artery ligation, ligation of descending branch of uterine artery bilaterally, then ligation of unilateral utero-ovarian anastomosis, and ligation of bilateral utero-ovarian anastomosis. So this is a nice picture which show the ligation of the uterines, then utero-ovarian anastomosis, all both the sides, so bilateral. So this is always a stepwise, and it is very, very successful. As we know, the uterus is richly supplied by these blood vessels. But this is a first line of treatment to control PPH at the time of cesarean delivery, of course, and it has got a more than 95% of the success rate. Most useful when hemorrhage is of moderate degree and originates mainly from the lower uterine segment. So we know that the uterine artery forms about 90% of the blood supply of the uterus. It increases twice in the size, and it runs upwards from the isthmus and enters the uterus and gives us so many branches. But the most important is ascending and descending branch. Now these uterines may split into 2 to 3 branches before they enter the uterus. So uterine artery ligation should be successful. More than one ligature might be required. You can see here, so uterus is so much richly supplied by these uterine artery and its branches. So one must tie once or twice. The procedure is very simple. It is done below the transverse incision or 3 centimeters below the loose attachment or UV fold in case of vaginal delivery. So you have to just separate the UV fold. You have to put 4 fingers behind one hand, and you should elevate the uterus. And you have to prick at the avascular zone of the Brad ligament when it is UV visualized. The suture commonly we use is Vicryl 1 or catgut number 2, and it should be passed 2 to 3 centimeters medial to the uterine vessels, and some part of myometrium is to be taken, and it has to be taken laterally from the avascular zone of broad ligament and tight. If not controlled, then same procedure you should follow on the opposite side. So this is just a pictorial demonstration or pictorial picture of showing the uterine artery which is tight on the right side. Here you can see that these are the vessels you can stepwise you can try. Here's the uterine, then ovarian anastomosis. Here you can just below the fallopian tube, and it should be usually unilateral, does not suffice, so you have to tie on both the sides. These are the steps we all know, so I will not repeat the steps. The steps are the same on both the sides. This is a lateral picture. You can see the anatomy and the relations, and how it has to follow the stepwise. So I just put, and this is, you can see here nicely the uterine exposed, and how it has to be, the uterine myometrium has to be included whenever we are ligating the uterine artery. So you have to tie one up and one descending also, both. So, and this is very important, that is a cervico-ischemic sutures and the uterine artery ligation. When these are, whenever there is a placental bed bleeding, you have to take some circular sutures on the placental bed. Along with that, you have to tie the cervico-ischemic sutures and uterine artery ligation. So 10 to 15% of the bleeding will stop with uterine artery ligation, and 70 to 90% it will when you do this on both the sides during pregnancy, because the 90% of the blood supplies from the uterine artery. So this is a famous study. We all know that he had studied about this Abdo-Rabo, studied around 103 cases, and he saw that it is 100% of the success rate. And 85% of the patients, they responded to the bilateral uterine vessel ligation, and only meager of the cases required the ligation of the utero-ovarian anastomosis. Now, what complication can occur whenever you are doing this uterine artery ligation? Bladder injury, ureteric injury, bowel injury, and broad ligament hematoma if you puncture it. That is most common with this uterine artery ligation. Now, what about internal iliac ligation? So it is always indicated before or after hysterectomy for PPH. Continuous bleeding from broad ligament base, profuse bleeding from the pelvic side wall or vaginal angle, or diffuse bleeding without clearly identifiable vascular bed, or ruptured uterus when the uterine artery may not be torn at origin, may be torn, may this side and that side, we will not able to know where it has so much there is a broad ligament hematoma, and we don't find its origin from where it is torn. Here we have to ligate the internal iliac ligation. Where the extensive laceration of cervix have occurred following difficult instrumental delivery. In these patients, definitely internal iliac artery ligation helps. And just a few lines about the anatomy. We all know, but just it is a repetition. The abdominal aorta bifurcates right and left common iliac at the level of L4 and divides at the sacroiliac joint into external and internal internal iliac arteries. And the external iliac, as all of us know, that is a principal artery for the lower limb. Internal iliac again provides the principal supply to the walls, viscera of the pelvis, and the perineum and the gluteal region. This is very important. These are the important relation of the internal iliac artery, anteriorly ureter, ovary, femoral end of the fallopian tube, and posteriorly we can see that internal iliac vein, lumbosacral trunk, sacroiliac joint, laterally external iliac vein between the artery and psoas major, inferiorly obturator nerve, and medially the parietal peritoneum. These are the important relations we always should remember whenever we are ligating internal iliac artery. And this I just showed you, anterior division and posterior division. We always talk of anterior division, there are parietal and visceral branches. Why I was talking about the visceral branch here is supply, that is a visceral branch gives rise to superior vesicle, uterine, inferior vesicle, middle, rectal, and vaginal. Now this vaginal artery is a direct branch of internal iliac, and many times we see that there is a colporaxis, and even sometimes I have seen the hysterectomy is done, still it bleeds. So in these patients, definitely it helps the anterior iliac artery ligation. So these are the various branches one should remember about the internal iliac ligation, and as well as the various relations. And it is very life-saving procedure. All of us should learn and teach our students. And Kelly, who 1983 was the first person to perform for uterine cancer, and later it was popularized by Mengert and Burchell. Then this is a popular question we always ask to our students, that how it helps. Now, what happens is the pulse pressure in the artery just distal to the point of ligation decreases significantly. And second thing is, when both the arteries are ligated, the pulse pressure even still decreases by 85%. And this reduction allows the blood clot to form at the site of bleeding from the damaged vessel. And the blood flow distal is also decreased by 48%. So ligation converts, this is the most important, is into arterial system, into the venous system, leading to the stable clot formation. And so it causes hemostasis. The procedure, there is anterior or lateral approach and the posterior approach. So that is, one is through the round ligament and the second one is from the pouch of Douglas. So this is how we ligate, and this is a picture how it is ligated. Now, about the round ligament of the lateral approach, after opening the abdomen, the uterus is eventrated, and the round ligament and the fallopian tube is identified, and 5 centimeter incision is made on the peritoneum between them. Then you have to enter the retroperitoneal space, which is very important, and that should be dissected bluntly with the fingers. The ureter always remains to the medial fold of the peritoneum and quite away from the vessel. That is very important. And directly one will be over the division of the artery with the little dissection. The adipose tissue, you can clearly see here the adipose and lymphatic tissue over the internal iliac artery, which is dissected with the caudal movement. What they say is a mixture should be passed from the lateral to the medial. That should be 3 to 4 centimeter away from the division beneath the internal iliac artery with a non-absorbable or absorbable suture, and this prevents injury to the external iliac vein. This is very common complication, and we faced this once, the injury to the external iliac vein. Then we had to call the surgeon who is the oncosurgeon, and then they tied this vein. It took around 3 to 4 hours to get the proper hemostasis done. They ligate the vessel with the 3 knots, palpate the femoral artery. This is very important. Otherwise, if you are tied the external iliac, then the femoral artery pulsation will not be there. Ensure the perfect hemostasis. Keep the drain for 24 or 12 hours and close the abdomen as usual. So this is one approach, and this is another approach that is from the pouch of Douglas. There is a posterior approach. The postpartum uterus is always bulky or large, about 24 weeks. So it is difficult little bit. Pelvic tissue are edematous and congested, and uterus should be exteriorized and held by the assistant. So opening retroperitoneal space through the pouch of Douglas is to be done. The assistant should push the rectum back, and then surgeon should hold the peritoneum and open the retroperitoneal space. The ureter can be seen transperitoneally on the lateral side. Here you can see them. And inserting the finger on the retroperitoneal space and gently widening to the exposed to the all the vessels, like vessels. The iliac vessels can be seen through the opening here. You can see here clearly. And then after exposure, you have to see the bifurcation of the common iliac, and then it has to be lifted, and identification is very important, and time is another one. So this picture demonstrates the vulnerability of the internal iliac vein. What I told was it is just below. So the adipose tissue, when you separate, it is common that the vein can be ruptured. That is a common complication. And then in this picture, you can definitely see the proximity of the external iliac artery, ureter, and the anterior branch of the sciatic nerve. So this also can be damaged sometimes. So these are the various complications which we get: the external iliac vein injury, internal iliac vein laceration and injury, ligation of the wrong structures like ureter, external iliac is very common, and the spasm. It can external iliac artery can go in spasm and thrombosis, injury to the internal iliac artery, and other complications like bladder atony, necrosis of buttock, bladder mucosa. Though they are rare, they are mentioned. Because of the good collateral circulation, the reproductive functions, post-ligation syndromes. So reproductive function is not affected. Menses they return normally, pregnancies occur, and reach term and without any intrauterine growth restrictions, suggest that adequate blood supply after ligation. So these are the few of the literature I searched, and they found that the overall procedure, they found that the complications are less and the reproductive performance is best after bilateral iliac artery ligations. So every practicing obstetrician must know about the procedure. It may be life or uterus saving procedure. So, and it should be tried before obstetric hysterectomy. So, and that is what we teach our students, that they must learn this internal iliac artery ligation and uterine artery ligation perfectly. And whatever the complication we face, they are transitory and rare. And it should be used as a prophylaxis to prevent hemorrhage and to secure hemostasis. We teach them during gynecological surgeries, and then when they are trained, they can definitely use them during their obstetric procedure whenever required. Now, what about peripartum hysterectomy? It is an emergency life-saving procedure which is performed when all other measures have failed to arrest hemorrhage. So it should be assertive and should make early decision for this hysterectomy before the patient exsanguinates. So one should not delay the decision, what we always say. And it is the most urgent. Delay in decision definitely leads to maternal mortality. So decision performing hysterectomy, you have to analyze the situation, evaluate options, whether we can shift, choose, and definitely act on this. Uterine atony and uterine rupture were formally regarded hysterectomy, and they're contributing to the growing numbers for the cesarean deliveries performed over last 20 years. As the cesarean rate is increasing, the placenta accreta and all those things are increasing. Now, for any hysterectomy, the consent is very, very important, and it should be anticipated in some of the cases. Like we know that this patient is having placenta accreta, definitely we have to take the consent. And when it is unanticipated case, the law definitely allows these surgeries if it has to save the mother. So one assistant is required to inform, always outside, we have to inform and take the consent, and we have to tell them that we have to save the mother. So patient has to undergo the hysterectomy. What about the challenges? Whenever we take the decision, we are always biased and always think of her age, parity, patient's condition, blood loss, and whether we can do further more interventions. So always many times the surgeries are unplanned, and the need for hysterectomy or any procedure, it is always go on compounded. The postpartum uterus does not present the same anatomical landmarks to aid the surgeon. So surgeon has to be anatomically perfect. And tissue planes, though they're easy, but they do not resemble their counterparts of non-pregnant situation. So these are the challenges we always face. And also the vascularity. The technique of the obstetric hysterectomy. So clamping, cutting the uterine pedicle first. So first clamp until the uterine arteries are secured, and then suture. So tying these pedicles. So clamp, cut and drop is a common technique what we use for the hysterectomy. Remove the cervix means some people say total and subtotal. There is really sometimes it doesn't matter. But it is very difficult to do total hysterectomy when there is so much bleeding, and there is no necessity unless the implantation of the placenta is on the lower uterine segment. So these are some of the situations. Those are difficult situations what I have faced, and these are the rupture. You can see the placenta previa accreta, and the posteriorly also the placenta is adherent. The studies have shown the bladder injuries and ureteral injuries, which are very common, though less. The ureteral injuries are less. The inadequate evidence examining different surgical approaches for hysterectomy, total or supracervical hysterectomy. So there are less evidences. Thus, the setting of an emergency postpartum hysterectomy surgical approach is felt to be fastest, and safety should be used in these patients. Now, what about traumatic PPH? Here also surgical management is required, like cervical vaginal laceration, vaginal and vulval hematomas. And we know about the risk factors in these traumatic PPH, like instrumental deliveries, when there is a macrosomia or the large for gestational age newborn, uterine rupture, or at cesarean delivery, the lateral extension, or there is a colporexis. Then if the incisions are made too low, not sufficiently curved on the lower segment, these are some of the practical things one should know. The incision, which is very small, but once the baby is taken out, the incision definitely gets extended. So most of the juniors, they will be operating, junior residents in the operation theater. So we get many of times lateral extensions very common. So whenever we talk of traumatic PPH, always repair the lacerations, ligate the vessel stepwise, and always do the hysterectomy if required. This cervical inspection kit should always be there in the labor room. This is a special retractor where it can retract the cervix properly, and the repair of cervical laceration, how it is done. So this has to be also taught, that how to explore the cervix, and if there is, after any instrumental delivery, to explore the cervix, and if there are any cervical laceration, they should be properly secured. Vulval hematomas are also many times we come across, and that has to be drained properly. And if the patient's hemoglobin is too low, many times the complications with smaller hematomas also, the patient comes in shock. And these I will not tackle much, I will not talk much, but many times disproportionate we get the shock. There is external no bleeding, but there are so many broad ligament hematomas. Then there is hematomas below the level of the pelvic floor and above the level of the pelvic floor. Ultrasound examination, proper examination, clinical examination will also explore that lithotomy position, adequately anesthetized, examination under anesthesia, and always, if possible, it can be drained properly. Local any bleeding points are there, that should be secured, and hemostasis to be achieved. So many times we come across such hematomas. Now, what about the interventions? Interventional radiologists to be called. In uterine artery embolization sometimes may be required, but limiting factors is one is availability of such an angiographyist or radiologist. The facility should be available, or patient should be relatively hemodynamically stable. So these patients can be referred to this uterine artery embolization as well. So I just want to comment that whenever the medical management is PPH is unsuccessful, surgical option should be utilized in a timely fashion in order to reduce maternal morbidity and mortality. One thing. Effective preparation, mobilization of the resources, and organized approach. These are the three things. And evaluation and the surgical management of these patients is very important. The multiple fertility preservation surgical techniques are now available. We should train all the residents, and that should be practiced to control PPH. Even though there are a variety of conservative surgical approaches which can be used, in a hemodynamically unstable patient, readiness for definitive management, as I told, is a hysterectomy, which is necessary many times, and one should not hesitate to do hysterectomy to reduce the risk of maternal mortality. So this is the statement by FIGO chair, Jerker Legistrand, who says that implementing this approach addressing PPH requires one is facility readiness, supply chain improvement, teamwork, communication, network integration, where staff communicate and collaborate between the facility, and local data used for troubleshooting and improvement. This is very important. And these are the various videos which Dr. Sheila Mane, our past vice president, she has done wonderfully with the model. They are available on the YouTube, and that can be used for training of our residents and postgraduates. So intelligent anticipation, skilled supervision, prompt detection, and effective institution of therapy can prevent disastrous consequences of PPH. So one should be acquainted where the medical management should be stopped, where the surgical management should start, and which patient, which surgical management should be applied. That is very important. Thank you very much for the patient listening, and thank you, Dr. Pratik, for calling me for this talk. I also just read about all these things, and just I came across these other sutures, but I don't know, I have not used, but I just read about this Matsubara Yano suture, and different various sutures are available, but we have not tried those sutures. Even they have got sling like sutures and all those things I just came across. Just I shared those sutures now. Thank you very much. And Bhagya Lakshmi, just I want comment, you're an oncosurgeon, so uterines, uterines and all those vascular pedicles, they are just a tip of your fingers. So you must have so many postgraduates and so many malignancies you have handled. So you are the better person. And you can give me tips and tricks about how to handle the surgical management of PPH. Yes, thank you.
Thank you so much, Dr. Vidya. I think you have done a wonderful job. But at this juncture, I think, and all the anatomy, everything you have shown so nicely. I think we should make it a point that when we are doing normal cesarean section also, they should peep into the anatomy a bit, because whenever they would really need it, maybe they would not be able to find it. So I think
Yes.
peeping into the retroperitoneum even during normal cesarean section will go a long way. But then we need to develop the skills of our youngsters. So I think webinars are doing a huge job, but then skill labs and hands-on training. So the skills have to be transferred. So I think through this platform, I can request Mox and Foxy to have some more of this hands-on training program.
I just
for a
this
younger-
practical obstetric committee is doing that internal iliac ligation, but unless
Yes,
I feel that feeling and that dissection should be a physical one only.
Yes,
Madam,
yes.
can I
So I
request you to please stop screen share?
Yes, I will.
We are delighted to welcome Dr. Kiran Kurtakoti, sir. He is a Vice President of AMOX, and sir was busy in a cesarean and he couldn't join us on time, but he was there just in time for Dr. Vidya Thobi's talk. He came in just at the beginning. Sir, your comments, please.
Yes, Dr. Pratik, heartiest congratulations to you. You have been a webinar person right through COVID times, and thank you for that. And really, it's a warm welcome from AMOX platform to Dr. Vidya. Vidya will be taking over as Kasoga next year as the president of Kasoga, and I'm sure I've already spoken with her that AMOX and Kasoga will have a good sort of a joint venture in the next year. So yes, I have heard the entire talk of Dr. Vidya, fabulous talk. And I would like to point out here that definitely all our postgraduates must learn the art of uterine artery ligation as well as the internal iliac artery ligation. Now, what is happening is we have a lot of courses of retroperitoneal dissection laparoscopically, where we are taught the endometriotic approach as well as the malignancy approach. But there are no courses as far as the open ligation is concerned, which is more simpler and more easier. So probably if there is a lot of hue and cry, you should not ligate the normal internal iliac, then probably you can place a shoestring knot which can be removed. So the students, the postgraduates, they can just pass in a mixture, tie the knot and remove the knot. That's a shoestring or shoelace knot, whatever is removed. So that can be taught to all our PGs. Now, what we are doing is for all high-risk patients that we operate for, especially for C-section, by default, we ligate the uterine arteries, not from the front, but from the back. So just above the uterosacral, wherever there is a transparency in the broad ligament, we just take a suture, bilateral uterine artery ligation, and the patients do very well. As a matter of fact, if at all you see these patients post-operatively, then they do have less amount of lochia. So probably that could be one of the way by which anemia can be prevented, because all these girls, they do not take iron and calcium post-operatively or post-delivery. They do take it antenatally, but not postnatally. So I think that could be one of the research or a thesis topic or a practical thing to do for our patients. So I mean, that's all. And Dr. Vidya, if you don't mind, if you could share your presentation, we can definitely request our web coordinator, Dr. Ajay, to put it on the AMOX website. So, you know, it's a very nice presentation that you have done, especially the supralevator and inflar levator hematomas, the pics that you have shown, very nice, and would be a great thing for our PGs also to learn. So thank you so much.
Yeah, I will definitely share. I will just modify because I was not well, so I did not do it well. I think I would have put some of the references and all those things. I could not do that, but I will do it nicely. I will edit it and I will definitely send it.
Yes.
Thank you, ma'am.
We will be shortly coming to you also, because we would want SOGOG participation also in the next year. I will talk to you one-to-one personally later on.
So we have a few questions which have come in from the audience. This is from Dr. Rekha Deshmukh from Thane, and she's asking whether, just like carboprost, we can give carbacin, that is carbetocin, intramyometrically in PPH. So that's not something which is recommended. The recommendation is to give it slow IV over 1 minute, and that usually takes care of more than 90% cases of primary PPH prevention. The next question is from Dr. Vaishali Raut. She's from Jalna. She's asking what is the most common cause of PPH these days. I think Dr. Leela Vyas mentioned it in her presentation that more than 50% of cases is atonic PPH. But more significantly, more than 50% of those atonic PPH, we cannot predict antenatally who is going to develop the atonic PPH. So prevention is the best cure, and we have to be prepared for atonic PPH in any patient. Most commonly, the patients who land up with PPH are the ones where you don't anticipate postpartum hemorrhage, where you are ready, your senior most consultant is there, anesthetist is there, intensivist is there. Nothing happens in those patients. They are absolutely fine. But when you're least prepared, that is when these patients will come into your.
So
any precautions
that's why
using injection carbetocin?
So I think
yes, ma'am, go ahead.
Every patient means you think of that. It means every patient can have PPH, and we should stop it.
Absolutely.
And definitely all the techniques. Which one point I just want to add that Vidya ma'am has explained very nicely each and everything. Pratik, you all can take this task that we make them to learn something about the obstetrics. You are doing anything but obstetrics. If you are OBGY, MS, DNB, or any of the degree DGO, you are there. The one or other day, the obstetric patient will come to you. And if you are a big surgeon, big endoscopist, they will think of that you are a big doctor. You have to, but you can tackle a most serious patient. So they should not leave this thing and make this understanding. And with them, ma'am, we have to take this also task that to make them learn this thing. And Bhagyalakshmi is also there, and Dr. Kiran has said that very nicely that it is to be explained each and every one candidate and make it as a compulsory for the every student to do this. As cesarean karke nikalte hain, one at least internal ligation, they should see that in their tenure.
Yes.
Thank you, ma'am. Dr. Swati Agarwal from Sikar is asking what is the minimum repetition time for carbetocin, and the simple answer is that it's not recommended to be repeated. It's only to be given single dose over 1 minute slowly, and if that fails to control, which is rare, then you need to go to second line and third line agents. The next question is from Dr. Shashikant Babhar from Malegaon, and he's asking what is the incidence of developing hypertension after carbetocin. The simple answer is so far we have not had any reported incidences of hypertension from literature that I can recall, but we will go back and we will check whether there is any isolated case report. The vast majority of patients have absolutely no issues at all. We have more than 1,000 people who are logged in to today's event, and they have watched two fantastic talks from Dr. Leela Vyas, our past Vice President of FOXI, and Dr. Vidya Thobi, soon to be Vice President of FOXI and President-elect of Kasoga. Thank you so much, both of you, for being here. Any closing remarks before I present the formal vote of thanks? Please feel free to go ahead and speak now.
Yes, this is to be a PPS to be in your mind, and you always think of that. These patients, any of the patient is going to deliver, she can have. So readiness is must. Your mindset like that to be a positive that we can save it. Yes.
Thank you, ma'am.
Thank you. Thank you very much.
Obstetric is a bloody business, as everybody tells. But the PPH is evergreen topic, and always we discuss medical management and surgical management. Even then, we are not bringing down the PPH incidence. So as Kiran was talking, the anemia and the risk factors, at least we know that PPH is not preventable, and in any patient PPH can occur, but at least assessment of risk factors and as Leela was talking, be prepared in at least those risk patients. That is the answer. Thank you very much.
Thank you, ma'am. Kiran sir, Bhagyalakshmi ma'am, any closing remarks, please?
Thank you. I've already spoken. Thank you.
Thank you very much. So at the end of today's program, I'd like to present the formal vote of thanks as the convener. Today's event was centered on postpartum hemorrhage, preventing maternal morbidity and mortality. I'd like to express my gratitude to the amongst office bearers, Dr. Rajendra Singh Pardeshi, our beloved President, Dr. Sujata Dalvi, our Secretary of AMOX, to the ICOG office bearers, Dr. Lakshmi Shrikandi, Chairperson of ICOG, and Dr. Ashok Kumar, Secretary of ICOG for the ICOG credit point, not just for this event, but all the other events as well. Dr. Kiran Kotukoti, sir, our Vice President of AMOX, joined us in person. Thank you so much, sir, for taking time out from your busy schedule and being here despite your OT. Dr. Bhagyalakshmi Nayak, our Governing Council member of ICOG and also soon to be, I think, Vice President of FOXY. Dr. Vidya, you have team competition. Thank you for both of you being here. We had two lovely talks by two excellent speakers, Dr. Leela Vyas and Dr. Vidya Thobi, who comprehensively covered both prevention as well as management, medical as well as surgical of postpartum hemorrhage. It's a very huge topic and they did fantastic justice to it, especially considering the newer molecule of carbetocin, which has now been launched by our academic partners, Glisson Pharma. Their molecule is not only heat stable, but also available in a pre-filled syringe form, and it's a patented formulation. So thank you, Glisson, for helping us conduct this event and taking it countrywide with the aid of Science Integra. Subbu, Ganesh, Sana, thank you for doing fantastic work behind the scenes. And most importantly, to the audience, 1,000 plus of you from all over the country who have logged in to watch this event. Until next time, goodbye, God bless. We hope to see you very soon in a couple of weeks, where we'll be talking about another important topic as far as high-risk pregnancy is concerned. Thank you for now.
Thank you.
Bye.
Thank you.
Thank you.
You
Thank
can
you
take us
very
off air.
Thank you.
Thank you.
Thank you so
Vidya
much.
madam.
Thank you so much, Dr. Pratik.
Thank you, Bhagyalakshmi.
Thank you.
Bye.
Bye.
Thank you all. Thank you.